The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to today's Kaufman Hall webinar, Developing Your MACRA Strategy. This is the second of 3 webinars in our series on MACRA. We invite you to access all of our MACRA resources at kaufmanhall.com/MACRA, and you can email us at macra@kaufmanhall.com. Just a few housekeeping items before the session begins. Participants will be in listen-only mode during the session. However, we do invite your questions, which you can submit at any time through the question box to the right of your screen. We'll answer as many questions as time allows during the Q&A portion of today's session. We are joined by Rob York, Chelsea Glenn, and Todd Fitz, 3 of Kaufman Hall's MACRA experts. Now, I'm pleased to turn the presentation over to Rob York.
Great, thank you, Rob. So just for those folks that were on the last session and also new to the second webinar here, this is the second session, part of a 3-part overall review of MACRA. And last time we talked about some of the technical considerations for MACRA specific to the final rule for 2017. Today's session is focused more on strategy and response to MACRA. And then we'll finish up in the new year with the 3rd installment of the webinars around more the financial impact and considerations from MACRA and how we go about planning for that at a more tactical level. So before we jump into developing your MACRA strategy, we would be remiss if we didn't talk about post-election MACRA. And we don't want to get caught up in crystal ball gazing with the election results, but only to really say what's on the next slide here, that MACRA had strong bipartisan support when it was introduced by the Republicans before, and we see MACRA as being one of those items that's here to stay. And there's some statistics here on the slide around the level of support MACRA had. And then the other second point beyond that really is what is the concepts and ideas that are bigger macro considerations that are represented in MACRA around the overall transformation of value-based care. A lot of those forces and momentum are not going to go away even with the election result, and so a lot of what we're going to be talking about today and in the next session still applies. We have 3 core objectives for today's session. First, developing your vision for MACRA. What does that really mean? And MACRA shouldn't be the overarching strategy and vision for the organization. It's really something that is almost a tuck into your existing organizational strategy. I think we've said this before, but the MACRA tail shouldn't wag the overall strategic dog. So what is it specifically we're trying to do as an organization, and then within that, what is our vision for responding to MACRA and the requirements of that program? And we're going to get into talking about the overall organizational readiness. Some of these will be favorites that we've learned to love over the past several years, but then there's a couple areas of focus that are really specific to being ready for MACRA and some of the things that we required into that program around clinical documentation and leadership and other analytics and capabilities that will need to have success in that program. And then we'll finish up with looking at our short and long-term strategic options or path in response to MACRA. If we look at the next slide, just to kind of organize the overall 5 steps here in starting to tee up our vision for MACRA. This is what we're trying to accomplish through this webinar series and in the materials that are on our website. But there's 5 steps as we see it to ensure successful response to MACRA in the final rule. With the first thing, understanding the requirements of MACRA and the education and across all stakeholder groups, not only clinicians but also executives and other players in the organization around what MACRA really means and the specifics of the final rule. Developing that vision for MACRA, as we just discussed, and understanding how that impacts our organization, but also fits into our existing strategy. Evaluating the current organizational context. So we've talked with whether it's population health or consumer or MACRA or many of the topics that we're dealing with as an industry. Our own organizational situation and market matter. So understanding that situation and designing a strategy that responds to the unique aspects of our own system and marketplace. Evaluating the various options underneath MACRA, like many of the other strategies around value-based and population health. MACRA is not a one-size-fits-all, and so we'll spend some time today talking about that. And then actually doing the execution, implementing the approach and strategy and initiatives to respond to MACRA. So jumping right through into the requirements, and folks that were able to join us in the last webinar got this in a lot more detail, and you can find much of the background on our website, as Rob Thomberg pointed out at the outset of the webinar here. The MACRA is a two-track program, with the first being the merit-based incentive payment system, the MIPS, so the replacement of PQRS and meaningful use and all of that good stuff, and really being focused around documentation and quality measures in those aspects. And then the second track, this concept of advanced alternative payment model, with the advanced being different than some of the shared savings like MSSP track 1 or bundled models that we know as alternative payment models. The advanced really representing the fact that this track involves taking more than nominal risk for organizations. And so most folks and physicians are going to fall into the MIPS track 1 at the outset, really not so much from a choice perspective, but just by default, and we expect much more activity in that particular track. So as we look at the next slide here, 8, and really with our first focus around education and understanding MACRA, and again, more details on this available on our website. Anybody that looked at the 2,300-page final regulation and the different implications of whether you're submitting quality through the CMS website or doing something else, there's just a lot of details to understand within the program, and it requires an investment in a multi-session type of approach and various means of education across your clinicians, management, and board to understand what the implications are. And for each of those audiences, there's a different level of depth you'll get into. And so there's some slides grabbed off previous sessions and next sessions and material off our website that just get into the complexities of around, okay, well, how does an actual advanced payment model qualification work, and what percentages do you have to hit, and what are the types of ways that the various measures under MIPS will be calculated, and so you can see some of that detail represented there. So that first and foremost step will be that communication plan and education for those various stakeholder groups. So 9 really just highlights one of the key takeaways from the last webinar, which is 2017, from what we thought the rule was going to be versus the final rule, has really become this transitional year. And so if anybody remembers the books that you could kind of pick a different ending and choose your own adventure, that's a little bit of what they've done for MACRA in this first year. So 2017 offers this Pick Your Pace program for physicians, and so there's various options that you can participate in that all involve, doing it all in, or picking shorter period requirements, or looking at reporting a few quality measures or even one quality measure in order to just get comfortable with. And some of the incentives associated with picking your pace really are around avoiding negative penalties for physicians. when you look at the changes, and some of this was around volume thresholds and other aspects, basically in these out years, and there's a graphic on the bottom of the slide here, or in these initial years, that most of the NIPS participants will be able to avoid that penalty in 2017. And so, there's some, again, a big part of this is the budget neutrality aspect of it, and it being a winners and losers program, but at least at the outset, it's designed in a way that many will be able to avoid the negative penalty. There's certain thresholds, as indicated here, in the composite score of 70, where you'll be able to trigger some of those exceptional performance bonus levels if you're a high-performing group. But again, 2017 being pick your pace and transitional, the key is to get everybody in and not harm them as much as was originally anticipated before we had a final rule. So jumping into the next section here around this vision for MACRA, and we alluded to this point earlier, and slide 11 really lays this out graphically. MACRA isn't the overarching strategy. It should be a tuck-in to what we're already doing as an organization, and some of that will become very familiar as we look at the specific requirements of readiness. It's not going to be all net new to all, or shouldn't be. But how does MACRA fit in with the overall organizational mission and vision and strategic plan, and how does it also relate to what's going on in our own market? Is our market moving fast through shared savings into risk models, and we have to be there anyway, or is it a little bit slower? So if we're going to make a commitment towards moving more towards the alternative or advanced alternative payment track, that we would be leading the market. All of that comes into play here. And maybe the best way to illustrate this, and we've had this conversation, in talking with an organization saying, well, we have to do something like next-gen ACO because we have to have a response to MACRA, and next-gen ACO being the most advanced version of the ACO model for Medicare, being risk and all in, and requiring you to be pretty advanced in all the capabilities to manage a patient population under global payment. That shouldn't be a conversation. We shouldn't be thinking about jumping from nothing all the way there if we haven't done that. So don't let MACRA kind of drive that decision making. Figure out where we are, where our capabilities are, and start to integrate MACRA in an approach and a response to that overall strategy. And the right side of this, the pie chart here, really looks and feels a lot like triple aim, but I think what's become more and more apparent and crucial around, again, and it fits in with this no regret strategy. I mean, it's never wrong to have, a highly aligned, organized, happy physician and clinician network. Is this pie piece around improved clinician experience. So any of the folks that have looked at the regs and look at all the fun associated with MACRA, it just adds to the burden in some ways that we're feeling with our physicians who are trying to do the right thing. And so a lot of what the overall strategy is, as well as our response to MACRA, needs to be an approach that focuses on that improved clinician experience, along with great patient experience and better health outcomes and lower costs. Don't forget about the clinicians in all this, and especially as you think about big implications within MACRA of needing to align those independent physicians that are really going to be impacted hard by this. So we'll finish up this section 2 around, again, continuing with this vision for MACRA and some of the key questions, particularly for hospitals and health system leadership, around figuring out what we need to do in response. And so most of these build off of the one, what is the level of employed versus affiliated independent physicians we have, and how are we helping both of those groups in response to MACRA. With the key theme being, if you're not talking to your independent physicians about MACRA, somebody else might be, and that could be not a good thing competitively. What are the appropriate steps towards offering our clinicians, and again, with our overall strategy, some of these advanced APM models? It's more of a leap for the industry, and involves taking risks. So what's our approach for doing that? Do we already have some of those that we can offer? Is it on the roadmap? What is the timing and requirements for getting those out to the clinicians? What's the investment associated with all of this? So certainly IT and analytics and other expenses, and we'll see some of this in the readiness assessment. Those investments need to, again, not be net new, but could be enhanced in certain ways and increased in certain ways as we think about ramping up and getting ready for MACRA, and particularly aligning those independent physicians that are such a big part of many of our networks. And then as an organization, as an enterprise, do we have the financial resources and also talent to really kind of support the overall provider network strategy and MACRA approach? So we'll need really a comprehensive look at all of these elements to understand how we respond and have success with our MACRA strategy.
Right. So moving to evaluating your current organizational context, as you'll see on the next slide, as part of the development of your MACRA strategy, you need to evaluate your organizational context from an external and an internal perspective. Looking outward, examine your physician network and the broader provider landscape within your local market to understand the degree of managed care in your market today. This will help shape your approach to MACRA and your trajectory toward value-based care in general. Internally, evaluate the clinical, infrastructural, and leadership competencies and capabilities of your organization to identify existing resources and potential gaps. Through this, you will gain a better understanding of your overall MACRA readiness. Understanding your external environment and internal position will help you in determining the pace and direction of your organization's MACRA strategy. MACRA is part of a larger push toward value-based care. You will need to look to your market to understand how this transition is playing out in your unique context and the broader implications of what is happening in your organization. So as you'll see on the next slide, moving into kind of the external look, evaluate your provider network relative to the evolution of your market, with a focus on 4 main areas. 1, network composition, 2, physician alignment, 3, competitive response, and 4, provider awareness and engagement. These 4 areas will help you in setting the pace and direction of your MACRA strategy and identify potential risks to your provider network. MACRA will have different impacts for different provider types, so before creating your MACRA strategy, assess your network composition. What proportion of your providers are employed versus independent? What is the mix of primary to specialty care, hospital versus ambulatory-based, and patient-facing versus non-patient-facing providers? For instance, hospital-based providers and non-patient-facing providers have separate requirements under the MIPS track depending on whether they file as individuals, under a group tax identification number, or as part of an APM structure. You will need to take these differences into account. Additionally, your provider mix will influence whether you pursue an APM structure and which models you choose, as well as the measures and reporting mechanisms that you select. For instance, if you have a large concentration of primary care providers, you would be eligible for different kinds of APMs, such as patient-centered medical homes, than if the majority of your providers were specialists. Depending on your organizational structure and situation, you may also need to have different strategies for different provider segments. And this flows into, you're not only looking at your network composition, but how your network is aligned. Through MACRA, CMS is encouraging the transition to value-based care and risk-sharing models. You will need to evaluate the current structures your organization has in place, such as clinically integrated networks, accountable care organizations, etc., and the incentive and compensation programs you currently offer providers relative to what is being offered in your market today. Being able to gauge where your market is headed will help you in setting the trajectory of your own transition to value-based care. In relation to your market, evaluate how current structures and provider incentives can be further leveraged to support your value-based care initiatives while protecting your network integrity. Finally, assess how you have moved your physician network, independent and employed, along the value-based care continuum already, and your planned trajectory moving forward relative to that of your market. This assessment will help you better plan for the pace and direction of your alignment strategy. Now, you need to not only look at your own network, but also at the competitive environment around you. Examine your position relative to your market. Consider how competitors, can you go one slide back? Sorry. Consider how competitors are positioning for value-based care. For instance, do they have ACO structures in place, and what payer arrangements are they pursuing? Understanding the overall direction your market is headed in terms of risk management will help frame and contextualize your MACRA strategy. It will also inform you of the options available to your independent providers and the consequent risk to your network integrity. Understanding the competitive response of your marketplace will help frame your provider engagement. The independent providers in your network will look at what resources and risk management structures you provide in comparison to your competitors. Assess providers' understanding and awareness of the push toward value-based care and how you are currently engaging them. Understanding that MACRA is just one piece of the larger movement toward value-based care. With its impending start date, MACRA can serve as a catalyst to begin to move your provider network down the value-based care pathway more broadly. So as you'll see on the next slide, the pace and direction of your MACRA strategy will depend on local market dynamics. To assess your network vulnerability, you need to evaluate your market's evolution with a specific focus on how physicians are aligned with the systems currently and how this may change through the transition to value-based care. Looking at market fragmentation, your strategy will differ depending on the degree of provider consolidation, where they are concentrated, and in what structures they are concentrated, such as independent practice associations, foundations, clinically integrated networks, ACOs, etc. The level of fragmentation can influence the pace of change occurring in your market, how quickly the transition to value-based care occurs, and what that transition looks like. Your network vulnerability will be affected by the spectrum of support services available in the market. Understand the value proposition that other health systems and provider groups in your market are offering. This includes more traditional practice management services, such as operations and supply chain, and more advanced managed care services, such as utilization management, referral management, and risk contracting. As you assess and plan for your support service offering, evaluate what your competitors are offering their providers and who is offering to help them compete in a value-based environment. Now, this doesn't mean you need to own all components of the care continuum, but you need to think about how services are offered in the community today in relation to your organization and network. This is all part of a broader assessment of the extent of managed care in your network. Regardless of your market's current state, you will need to move quickly toward value-based care, not only for your Medicare population, but also for other public and private payers. The extent of managed care in your market and your own organization will affect the transition, the pace of this transition. The extent of managed care in your market today influences providers' familiarity and experience with value-based care services, and this experience will impact your market's readiness to design and implement more advanced care management and value-based practices. So in thinking about the impacts on physician alignment, you'll need to assess the degree of product sophistication and narrow networks in your market. How quickly is your market shifting toward limited networks, and how are you navigating this transition? What contracting strategies are you pursuing with purchasers? What is the impact of being excluded from certain networks? These questions are important as you move toward value-based care in both the public and private spheres, and as you decide to take on more risk with specific patient populations. Consider how the overall movement toward narrow networks and the risk of network exclusion could impact your physician alignment. Now, you'll also need to assess the level of vertical collaboration in your market. How is the payer-provider relationship evolving in your market, and what kinds of collaboration and or integration are occurring? This shift to value-based care requires providers to control the cost of care directly. Providers are moving to take greater control of the premium dollar and develop the capabilities to improve total cost of care. MACRA integrates cost management into provider reimbursement, which will have repercussions on the type of services and alignment that providers seek as they compete under MACRA. The services you offer to providers to help them address total cost of care will have an effect on your network alignment and vulnerability. So moving to the next slide, you'll see that now we've looked at kind of the external context, and so looking more internally, the second part of your evaluation is an internal readiness assessment. Now, we've outlined 8 critical competencies required for success under MACRA, which we organized into 3 areas. 1, clinical and operational capabilities. 2, infrastructural capabilities. And 3, leadership capabilities. So in the next few slides, we have provided a list of questions to help frame your internal evaluation. The purpose of this activity is to help you identify organizational weak spots so that you can prioritize resource allocation and understand the timing and resource constraints in planning your MACRA strategy. Finally, this assessment can be done at a system level, but also at sub-levels such as your physician groups, an affiliated IPA, or an ACO within your organization. So starting with clinical operational capabilities on the next slide. This area focuses on competencies that enable patient care services to be coordinated across people, functions, activities, processes, and sites in a way that maximizes the value of services delivered. MACRA emphasizes team-based coordinated care delivery, so you will need to assess capabilities such as utilization management, referral management, transitions of care, chronic disease management programs, and use of evidence-based practices and protocols to better manage patient care, especially for high-risk, high-use patients. Now, the Medicare population has disproportionately higher healthcare use and costs, so improved clinical documentation and care management processes are critical for competing successfully under MACRA and also just more generally managing this vulnerable and rather high-volume population. Finally, physician incentive and compensation models should align with value-based care objectives, and you will need robust clinical documentation mechanisms to ensure that your record of care reflects provider performance. These incentive alignment models apply more broadly than MACRA as well, encouraging providers to better manage patients and incorporate cost and quality considerations regardless of payer type. So moving to infrastructure on the next slide. To perform well under MACRA, providers must be able to accurately and efficiently document and report their performance. Organizations that support providers by offering data analytics and business intelligence capabilities enhance providers' ability to navigate reporting requirements, measure selection, and quality and cost improvement efforts over time. Strong data analytics can help identify areas for optimization, and the implementation of technology infrastructure can help drive clinical standardization and quality control. This competency set moves beyond just maximizing your information technology score under MACRA. How you use analytics can differentiate your overall clinic network performance. And so finally, leadership on the next slide. A successful MACRA strategy will require the engagement of key stakeholders across your organization. Clinical, administrative, and governance leadership is required to drive operational, strategic, and cultural change. You will need to involve providers in the development of your MACRA strategy and your broader value-based care pathway, including educating providers about the transition to value-based care. Part of strengthening your clinical network is providing knowledge resources and increasing participation in managed care structures. So what is the overall takeaway? As part of the development of your MACRA strategy, assess both your internal and external context. Analyze your physician network vulnerabilities in the context of your local market, and examine your internal readiness based on your clinical, infrastructural, and leadership competencies. This assessment will both help identify gaps and highlight opportunities to guide your overall MACRA timing and strategic decision-making.
Thank you, Chelsea. That was an excellent overview of the capabilities required and the things you should consider as you understand your readiness and start to plan on the strategy. And given what Rob said, planning that strategy in the context of a much broader value-based and organizational strategy. And some of you might remember, if you joined us for the first presentation, the graphic on the first page of the next section, which is really outlining those three main paths we have in front of us in the big decision going into the transition year of 2017, which is, which of these three paths are we going to choose to start our efforts around MACRA, but appreciate that where we start may not be where we end up over time. And and I won't go into a lot of details of those different paths. We covered that a lot in the last webinar, but it's important to keep in mind that the keys here are these different paths have different implications associated with them, the capabilities you're going to have, the levels of performance you're going to have to deliver on, but then also have a corresponding impact on what you'll get paid. So the more sophisticated and capable you are in delivering quality care, the more upside potential you have. The one option we don't have on here but does come up in some conversations is, of course, the do-nothing strategy, which may be in play for small providers with little Part B revenue, but for most of the folks on the phone today,
I would suggest that you should be considering one of the three here. So when we think about the bigger picture strategic options as it relates to MACRA, there's three areas we're going to touch on briefly here today. One of those is clinical alignment. So how does MACRA get influenced by our clinical alignment, which would be some of the readiness assessment that Chelsea touched upon. But also, what opportunities does MACRA offer us to improve alignment and allow us to engage physicians, allow us to engage in helping them build capabilities, and drive alignment as just another lever in our broader scheme of building alignment. The second one is what we have risk management, or maybe risk arrangement management, which is what types of risk to what degree are we taking overall, how does MACRA fit into that, and vice versa. And this is one we'll talk about a little bit more in a second, but with a lot of these, it's both it's a strategy in and of itself as well as being impact from other strategies. So for example, MACRA can be a means to an end to help us get further into risk-based arrangements, or everything we may be doing already leads us to certain MACRA strategies and capabilities. You need to consider that based on where you are as an organization. And then lastly, the financial impact, and we'll touch on kind of the bigger picture aspects of that, but as was noted earlier, our next webinar will go pretty deep on the financial considerations. So in thinking about the clinical alignment, many of you are probably already experiencing some inbound calls from physicians, especially independent or community physicians, as they start to get a little bit more concerned about the impact of this and what it means for them and how you're going to help them. But that's been very variable as we've worked with organizations across the country. Some markets and some physicians have their heads in the sand, and it may take a more proactive approach by the providers to engage them in this conversation. Thankfully, there's enough information out there now so you can start to have that conversation and hopefully get them on board with making some at least near-term decisions around what to do in 2017. But the ones that are obviously going to be more sensitive to MACRA are those smaller practices that don't have the capabilities nor necessarily the need historically to build out value-based competencies, and most of which Chelsea touched upon. But now as this is looming and they think about the investments that will be required to accommodate the ability to maximize their reimbursement under MACRA, they may be looking for support, either to develop those capabilities or to finally say, you know, we need to join a part of a larger organization because the benefits of scale here are real and meaningful. And then obviously, you know, the practices that have higher proportions of Medicare Part B revenue have the most exposure to this and will be more sensitive and more interested in engaging that conversation. The structural alignments are variable, and there's many ways of going about this, and I'm sure most of you will employ a whole toolkit of alignment options, including employment, clinically integrated models, networks, ACOs, and so on. Or maybe looser arrangements like joint ventures. But it is important to kind of have that multifaceted approach because we still see, both from a market perspective as well as a practice type perspective, for most folks, no one alignment structure is going to get them to where they need to be. And Rob touched on this earlier, you know, as you look at your market, as you look at how it's evolving, as you consider your overall approach to contracting and taking on risk, you need to consider that big picture, not just Medicare, and understand what that evolution looks like and where those lives are distributed, because ideally you are maximizing your investments as you transform the organization from volume to value, and to do that, looking for opportunities to leverage those capabilities across a variety of payers and types of arrangements, and doing that in a way where you're going to be successful, because there's always the opportunity, as the risk increasingly includes downside opportunities, that you get in a little bit ahead of yourselves. For those organizations that are more advanced, and we've seen this already in many places, the question needs to be, are you an actual driver of that transformation in the market? Can you actually be one of the people pushing the market to value, whereas for most people that's still being dictated by the payers. But some places are able to do that on their own, and done in a smart way, benefit from that, both in terms of share as well as in financial performance. From a financial standpoint, the direct and indirect ones are fairly obvious. There's the revenue upside and downside, and the investments to be made to gain competencies where you maybe don't have them. Indirect, maybe not so clear. As we build these capabilities, as we get better at managing care and outcomes, there can be impacts on performance, operational improvements. Hopefully, and again, you need to understand, while you may be reducing costs, how does that work from a revenue standpoint, and are you actually making more money, or are you saving the cost for somebody else? That's always a key consideration. Hopefully through this and your engagement of physicians, especially in competitive markets, if you do this well, you can grow your footprint and grow your relationships with physicians, which will have a benefit probably far bigger and broader than MACRA itself. So this offers an opportunity, again, to engage in those conversations. And then the indirect costs, kind of the inverse of that, is that if you don't do this well, there is some strategic risk. There's strategic risk in physicians aligning with other organizations. There's strategic risk in your community physicians underperforming as it relates to MACRA and being penalized or having their revenue fall short, which can create a variety of problems. One, physicians retiring early, moving out of the market. Two, the more extreme and direct impact on you all, which is looking to be employed, and the costs you'll incur to do the transaction and support those ongoing operations. One that's not noted here that we don't quite have a handle around is, I know for most of you, your ability to recruit and retain the physicians you need to deliver the care in your market is often challenging, particularly for primary care. Because there's the volume and dollar threshold, there is the question as to whether physicians near that threshold will just opt out of Medicare and not have to deal with this, which is just going to create further access problems for you. The threshold's relatively small, so that may not come into play as much as we might think, but it's still something to maybe consider, especially if you've got some visibility into physicians that might be on the line and getting an understanding of what they might be thinking. So, as you think about those strategic options, the big idea to keep in mind, we talked a lot about understanding the market and where the physicians are at, using this as an opportunity to increase alignment with physicians and as a great way to engage in conversations that maybe have been difficult in the past because the physicians, haven't had an interest or haven't had a driving need to get into some of these conversations. The sensitivity around how far, how fast is very important. It's very easy to get in over your head. Some of these investments can be significant, and if you make them in the wrong way, in the wrong time, then that's lost capital. And so we say, how quickly can your organization progress, but it also should say, how quickly should you progress? So thinking about that broader strategy, how you need to spend your limited capital, how you're trying to execute much more broadly as Rob said, macro should not be the tail wagging the dog. It really needs to be part of the overall strategic consideration. The infrastructure gaps, so the readiness assessment, some of those things that Chelsea touched on, getting a good sense of those if you don't already is key. Some of those things take time. We do have the benefit of the transition year, but if you want to get down that curve into the more advanced models more quickly, we need to start planning for those, building out those capabilities, planning for them financially and investment-wise, and getting to them so that when this, as this ramps up over the next couple of years, we're in a position for success. And then, what are those other local community factors, whether it's what the payers are doing, the insurers, what are the provider competencies in the market, and what might be your role in helping those develop, all need to be part of that strategy and that vision out of the gate. Appreciating, again, that your macro strategy and, honestly, your overall value-based strategy is a strategy that needs to actively evolve. This is not a 5-year strategic plan that you're going to have dialed in out of the gate. This is something that you really need to manage actively, which we're not always so good at doing. So implementing the macro strategy, kind of the last content slide here, I think most of this is pretty obvious. And I just touched on this, is, how are we going to track our performance over time? How are we going to measure our evolution? How are we going to be able to make smart decisions on where and how to enter risk-bearing agreements? Macro dictates a lot for us, but we're going to have a variety of things coming to us, if not already for most of you. How do we make decisions around those, and how do we be successful is going to be a big part of how organizations perform financially really over the next 5 years. So we're nearing the end here, and we've got time for questions. If you do have questions, there's a little box there on the interface. Please submit those to us, and we're happy to answer them. But as you supply those questions to us, just a reminder that financial impact webinar, where we'll go a little bit deeper on how to assess and model the impacts of macro on your organization, is coming up January 12th, which seems like a long ways, but it'll get here quick with the holidays. And if you want to register, that's available on the website. These materials, as well as a variety of other materials like our MIPS calculator and the previous webinar materials, are all on our website at kaufmanhall.com/macra. So that's available to you at any time, and we hope you find value and engage in some of those. And then lastly, if we don't get to your questions today, or as you get other ones as you move forward, we've set up an email address, macra@kaufmanhall.com, where we're happy to entertain any and all questions you might have around macro or physician engagement and alignment as you try to figure this out. So with that, we'll stop for some questions.
Thank you, Todd. We have some excellent questions already received. The first one I'd like to pose, and Todd, I suspect this one is going to be heading your way, is what are some specific things that physicians can do to make their MIPS composite score as high as possible?
Well, this might be a better question for Chelsea, because she knows the nuances and probably done all the math to figure out sort of the best approach. But I think generally it's one, because you have the benefit of selecting what you report on, is being smart about what you select to report on, right? So you can sort of pick the things where you might perform a little bit stronger, pick the things that you have better capabilities of measuring and reporting on, because that's obviously important. But it's, really, because you have those 3 paths in the near term, it's can we get as aggressive, if you will, as possible to get into the APM track if possible and maximize our potential upside, because again, with each of those paths, the payment levels are different. and limited based, on how sophisticated and how aggressive you are in engaging in MACRA. Chelsea, I don't know if you have anything to add to that.
I mean, I think you hit really great points. The only thing I would add to kind of your customization and flexibility piece is the different reporting mechanisms have different measurements that you can choose to report on and different ways of reporting to CMS. So better understanding those and making sure that you're using the correct mechanism that best represents your group or you as an individual. And then also just how you're reporting, if you're reporting on an individual basis, what that means for your measure selection versus if you're reporting as a group, what the specialist versus primary care mix is of that group. So thinking of all of those things as you try and optimize your MIPS strategy.
Great, thank you. Another question is whether your organization, specifically if you're a community health network, will be at a disadvantage if you do not have your own payer arm.
So I think that, there's a perfect example of a question that every provider, whether they're community, AMC, large multi-state system are asking around the country, which is, one, what does risk mean? Do I need a risk-bearing capability or entity to thrive in this future environment? So, again, markets matter, organizational position matters, and so we've seen it done both ways. I think that, without understanding the specifics of your market and an organization, that access to a risk-bearing capability or purchaser relationships, as we'd characterize them, is more important than actually needing to have that under the tent. And so in a lot of situations, we've had organizations who want to move the needle and want to take risk and are ready to do so, try to go out and do that. And sometimes they're able to construct those relationships with the payers and the purchasers in the market, or they have to create other means to do that, and that could be, although it's few and far between, starting their own health plan entity or product in the marketplace, or accessing somebody else who's done that in another market and being able to purchase those capabilities. So if you think about a triple threat for success in value-based population health, this environment we're talking about, we think it's three things, and many of them came up in the macro conversation. It's certainly a vibrant health system and everything, services and all that stuff that goes underneath that umbrella, an integrated provider network that's effective, that's both economic and clinical outcome driven, and then access to that risk-bearing capability. So it is important, and again, it's a market and organizational question to say, can we get access in an effective way to drive our strategy? If not, you may have to look at getting that capability a different way, because you will be disadvantaged if you can't leverage that to drive a true value-based strategy.
And sort of a cousin to that question is whether we see a competitive advantage for if MACRA creates a competitive advantage for large academic medical centers versus community health networks.
Well, there's probably not a yes or no answer, but I would think, if anything, most EMCs are going to be disadvantaged. I mean, they have the benefit of scale to be able to make some of these investments, but they're traditionally not set up to deliver on a lot of things that value asks of them. And so, focusing on driving care out of the hospital around quality, around low cost, around engaging a broader physician network, including community docs. A lot of the conversations we get in with academic organizations now is their biggest challenge is, some given history, some just being natural. They're at a point where the engagement of the community docs, the non-faculty docs, is fundamental to their strategy, and most of the community docs don't have much interest and in some cases have negative thoughts of doing that. So It's possible. I just don't see them having a competitive advantage other than, a little bit deeper pockets typically, to deliver.
Yeah, and even if we just take, academic, non-academic, take that characterization out of the equation, I think that in general, there's a competitive advantage and thought right now that if you already are a higher performing physician group, regardless of who you're associated with, that you do have a competitive advantage. And even if you can do alternative payment models, APM, that you might pick the MIPS track because you're already using that, you're reporting that, you can pick the measures, and you actually for a period of time can beat that threshold and trigger those bonuses and multipliers and basically, and for lack of a better term, kind of game that system or operate on that MIPS track before you absolutely do have to take it. So yeah, academic, non-academic, just take that aside. There is a competitive advantage for high-performing physician groups, integrated groups, to really look at this thing and say, I can beat that and pick my measures. I'll take the bonuses when I can, and then I'll flip over to the risk and APMs on my overall strategy whenever I need to. But right now, there's an arbitrage opportunity in some ways on MIPS in their mind.
Yeah, and to build on Todd's point, one additional point, as the resource usage, resource utilization metric comes into play over time within the MIPS track specifically, that will certainly be an area of focus for academics that may, you could say more traditionally, have not been able to perform as competitively against the community providers and community hospitals out there from that specific measure. So that certainly, as Todd pointed out, provides another challenge for academics out there.
Great. Thank you. That was Anand Krishnaswamy weighing in with some additional information from Kaufman Hall. Another question we had is whether we could define what we mean by vertical collaboration.
So this is Rob Bjork. I'll start. So we characterize, and this is actually one of the factors we look at in any kind of market. So this is in reference back to the map of the United States that had the various plot points on it in terms of saying, understand where your market's at and figure out, both can you move, but should you move, and when should you move on some of these vehicles, more related to the vehicles around taking risks. So vertical collaboration, the way that we're defining it and using it there, is the level of, to go back to the earlier question around, do we need to have a health plan or risk-bearing entity inside the organization? So it is the level of partnership and strength of that partnership between both the providers of healthcare services and the payers or purchasers of healthcare services in a market. So to give it one example, look at an organization like Tandem in the Philadelphia marketplace, which is a joint venture with Independence Blue Cross and an organization by the name of DaVita Healthcare Partners, which is out of the Southern California marketplace Healthcare Partners model, to basically create a joint venture between primary care physicians in that market and the payers to manage populations at a lower cost of care, given the high use of hospital services in the Philadelphia market. And so that's a real strong company, joint venture, collaborative effort between the payer in that marketplace and the providers to drive value-based care. And so there's lots of forms of those around. Some of them are direct with employers. Some of them are, again, vertical collaboration goes away because the health system has the health plan and they are already integrated. But it's really just focusing on how tightly the purchasers are working with the providers in the marketplace to advance those products and make them more sophisticated and make them more wired towards risk. If you've got a lot of that, the question around should we do risk or APMs is probably an easy one because the market's already going there, and if we're not doing that, then we're not at the community standard. So it's been decided for us. If you're in one where there's not a lot of that going on, there may be an opportunity for you to lead with one of those partnerships, or maybe take a slower path and look at more shared savings because there's not a lot of heavier partnerships pushing that.
Excellent. One other question we have, and this may be the last one we have time for, is who should be in the room? Who are the key players who should be involved in developing an organization's macro strategy and making sure it aligns with the broader organizational strategy and strategic plan?
Well, it's probably the same group that increasingly needs to be involved with just setting the overall strategy. So that table's expanded a little bit in recent years to become a little bit more clinical focused, bringing in addition to sort of the leadership of the organization, particularly financial leadership here, the chief medical officer, depending on how you're structured for physician engagement, physician integration, the physician enterprise, leadership there. If you've got an employed physician group of size, it's probably that leadership. It's really good and often not done to have someone at the table with kind of deep knowledge of the contracting side. It's usually kind of left as an afterthought, or the CFO is kind of assumed to have some of that, which to a degree they do, but they don't necessarily understand the nuances of these agreements and how they're evolving. And this is one area where the details matter. Those nuances matter, and these contracts are becoming increasingly complex and difficult to model out for organizations. So that's another important add. And then technology is such a big part of this. So information technology leadership that understands the capabilities, understands those gaps, hopefully also includes the data and analytics and reporting, but if that's another add, then that's, so it's a pretty big table, obviously, but there's a lot of facets to this that if you don't understand one of them or you miss one of them, it could be a pretty big miss. And speaking of miss, did I miss anybody there? Rob, Chelsea?
No, I think you covered it. I mean, again, as we've seen as an industry, right, it's not just the CIO anymore. You've got CMIOs and all of these folks that are bridging, between the clinical data sets and the financial data sets, and understand how all these pieces come together. And as outlined by Chelsea in terms of MACRA, that reporting requirement, coding, clinical documentation, how it all gets there is a pretty important part of the success story for this. Those people are pretty critical to that.
Well, thank you very much. Thank you, Rob, Chelsea. Thank you, Todd and Anand, for jumping in on the question portion. A couple of important notes. We did get several requests for the material associated with this presentation, which we will get out to folks. So thank you for your interest. The website, kaufmanhall.com/macra, really does have a lot of rich material. There's an online MIBS calculator, all the way to a presentation on the basics of macros. So that's a great resource for everybody. And finally, please join us for the January 12th webinar. The link in your presentation materials will help you register. And most important, thank you everybody for taking the time and for entrusting us with this hour to get more information about an important topic. Thank you so much and have a great afternoon.